Hello, everyone. Thank you for coming. Welcome to NAHDO's 38th Annual Conference. We will be starting in about 1 minute. Before we begin, we want to cover a few housekeeping items. On your attendee screen, you can enter comments in the chat and questions in the Q&A. We hope you will take advantage of this opportunity to engage with our speakers and attendees. This session is being recorded. We recognize and thank the California Healthcare Foundation for being our Petabyte sponsor. Information about all conference sponsors is available in the sponsor area of the platform. Please take a few minutes to visit each sponsor's booth where you can find information about them and find game tokens. Game tokens are keywords or phrases used in the token hunt game for a chance to win a prize in our daily drawings. Now, let me turn the stage over to Norm Thurston, NAHDO's Executive Director. Norm, the stage is yours.
Oh, thank you, Erica. It's wonderful to be with you again for our 38th annual conference, this year again fully virtual. My name is Norm Thurston. I'm the Executive Director here at NAHDO, the National Association of Health Data Organizations. We would like to first of all recognize our NAHDO event sponsors. As you can see on the screen, we have a lot of them this year, and we're very excited about that and thrilled to have their support. Our Petabyte sponsor is the California Healthcare Foundation. Terabyte sponsors are Friedman Healthcare, Mathematica, Milliman MedInsight, OnPoint Health Data. Our Gigabyte sponsors are Barry Dunn, Comagine Health, Equanim Technologies, HSRI, Medicasoft, and the Peterson Center on Healthcare. And our Megabyte sponsors are CareQuest, Mercer, Optum, and the United States Census Bureau. We'd also like to call special attention to our NAHDO strategic partners. Our collaborating partners include Friedman Healthcare, Mathematica, Milliman MedInsight, and OnPoint Health Data. And our NAHDO featured partners include Barry Dunn, Comagine Health, HSRI, and Medicasoft. Since last year, we've also had several new members join us. We would like to recognize and thank them. And that includes Formedica, Incena, the Georgia Office of Health Strategy and Coordination, Midwest Health Initiative, Mathematica, Oklahoma Department of Health, the Nevada Department of Health and Human Services, and Synchronous will be joining at the end of the year. If you're not currently a NAHDO member, we encourage you to join NAHDO today. Of course, we couldn't do this without our NAHDO board. We have some of the best volunteers in the world serving as NAHDO board members, representing you as NAHDO members to make sure that our organization is meeting your needs and working to help you. The Program Planning Committee also deserves a special shout out for the obvious and wonderful things that they have done to make this program even possible for you today. I'd like to just call it a few pro tips for attendees. Platform features are a little bit unique to this platform. If you haven't been as part of the WebEx Socio platform before, we would like to point out a few things. The conference program is a PDF version of the agenda, which will show you everything all at once. But we also have the inline agenda, which will take you directly to sessions that you may want to see. Of course, there is the token hunt, where you can win prizes. Today's prize will be a $25 Amazon gift card, and that will escalate up to the grand prize of a $250 Amazon gift card on Thursday. Every time you see a token on screen or you find one in one of the areas, go ahead and just pop over to the game token environment and enter that token for a chance to win a prize. Of course, one of the best things about conferences is the opportunity to engage with others and to network. It's a little difficult in a virtual environment to do that one, but we've got some ideas this year that we think will really work. So during each afternoon, there'll be a break in the middle where we will have networking sessions. They're called Health Data Deep Dives, where you can get together with a small group of people, turn your camera and mic on, and talk about something that's interesting to you. So we encourage you to try that out today. Give that a shot and see if you can meet some new people and talk about topics that are interesting to you. Of course, the sponsor booths are out there as designed to be a resource for you to help you to learn more about our support group and the people that are helping to make this possible. One thing that people don't really realize is that you can find people and connect with them directly through the attendees list. So if you go to the attendees list and find a person, you'll be able to connect with them through the conference platform. And then, of course, if you're a social media person, we have a built-in social media platform. It's called The Wall. And you can write whatever you want on the wall. Well, not whatever you want, but something about the conference on the wall, or share general thoughts or ideas. And we hope that you'll take advantage of that opportunity to tell us what you're thinking and what you're working on and share that with others. So the wall is, again, another opportunity to engage and to network. Finally, one exciting piece of news that we will be in person again next year in May 2024. We will be in New Orleans at the Hotel Monteleone. We're so excited to be again in person like we were this year in Boston. We're going to do it again in New Orleans. It'll be a great time. You'll be able to meet other people. And of course, these are networking meetings. The idea and object of showing up to our in-person meetings is to get to meet other people. We hope that you'll mark your calendars. This year, it will be capacity controlled. So just make sure that you register early, because once we hit the limit, we won't be able to add any more participants. Now, for our first NAHDO award, this award was already presented at the in-person meetings in Boston, but the 2023 Elliott M. Stone Award was presented to Karen Lee Harrington of the Maine Health Data Organization. As many of you know, Karen Lee has been a fixture among NAHDO and in their health data organizations for many, many years, most recently serving as the NAHDO board chair for the last 3.5 years. So again, hopefully you'll have an opportunity to look at Karen Lee's full citation at nahdo.org/awards, and maybe just drop her a little email congratulating Karen Lee for her accomplishments and for her recognition. At this time, I would like to turn the stage over to our current board chair, Kenley Money from the Arkansas Center for Health Improvement, affectionately and respectfully known as ACI to most of the world. Kenley, are you ready to join us?
Okay.
All right.
Good morning. All right. Good morning, everyone. Though Norm just introduced me, I'll introduce myself again. My name is Kenley Money. I am the Director of Information Systems Architecture and the Arkansas All-Payer Claims Database Director at the Arkansas Center for Health Improvement, ACI. First of all, is everyone able to hear me? Norm, am I coming through? Yes?
Yes. Fantastic.
Okay, thank you. I am honored to serve as the chair of the board of directors for the National Association of Health Data Organizations, or NAHDO. For those of you who are not quite as familiar, that's what the acronym is for. The NAHDO board of directors, as you saw a moment ago, is comprised of 17 subject matter experts in health data solutions, which include state-sponsored programs and teams, as well as the highly skilled and knowledgeable organizations that support them, including but not limited to NORC, OnPoint, Freeman Health, Manette, etc. During the next 3 days, you'll have the opportunity to interact with all of them, and I urge you to do so if you can. I want to especially recognize the NAHDO Executive Committee, who work in concert to help manage the chaos of an accelerating need for healthcare cost and quality data. And that's the focus of NAHDO's mission, to improve healthcare data collection and use. My fellow executive committee members are Kevin McCabe, Director, Manette Health, Vice Chair; Janice Bourgeau, Senior Director of Product Development, OnPoint Health Data, Secretary; and Angela Taylor, Data Architect and Senior Manager of the Kentucky Cabinet for Health and Family Services, Treasurer. Hopefully you will speak to them throughout the conference. And we are here to support NAHDO's Executive Director, Norm, whom you just met, and his intrepid Director of Projects, Charles Hawley, as they guide NAHDO through the health data landscape to provide thoughtful, timely, accurate, and most important, valuable and useful support and technical assistance to NAHDO's members and partners. NAHDO's been a leader in the development and implementation of national standards for hospital discharge data, and is collaborating with the Public Health Data Standards Consortium, the APCD Council, and America's Health Insurance Plans, AHIP, to develop core APCD reporting standards for state-based claims data systems, among other things. I have attended many NAHDO conferences over the years, not as many as some of our illustrious members, Kathy Hines and Linda Green. I'm thinking of you. I hope you're on. But enough to have witnessed the evolution and change in subject matter. I remember when the primary focus was inpatient hospital discharge data, and APCDs were the new kids on the block. Now the health data environment has changed, and the utilization and integration of these data systems are becoming the norm. Dare I say legacy type systems? This change is evident in the topics covered in our conferences, of course, we have always shared expert experience and best practices in areas such as data quality, infrastructure, health data analytics, social determinants of health, etc. This year's conference will not disappoint. There are many sessions on data linking, innovations, dashboard reporting, privacy, consent, governance. Personally, I'm looking forward to today's session, methods of deduplication of member eligibility data. Yeah, that's me. I'm that kind of nerdy that way. But lately, the subjects have broadened to include climate change. I heard that for the first time in our August conference in Boston. And AI, last week's hot topic session. To me, these solutions, the new solutions, and what some would call scary solutions, mark a change in our forward vision. Could it be that the core of our health data assets, APCD and hospital discharge data are becoming stable enough that we can look more toward the horizon? I think so. Change is hard, change is frightening, but we have to have the vision first. This year's NAHDO conference has plenty of that. Enjoy, and thank you.
Thank you, Kenley. I would now like to introduce Craig Schneider from Health Management Associates, who will introduce our keynote speaker. Craig is the program committee chair and has personally organized this session. Craig, let's bring you to the stage. Charles, can you bring Craig? Great, Craig, it's yours. Take it over.
Hi, good morning. Thanks very much, Norm and Kenley, and thanks to all of you for joining us today. In this remote work environment, I think you're getting a good look at my daughter's room, which has recently become my home office, and I haven't had a chance to update the decor yet, but we'll soon. For today's session, we're thrilled to have one of the nation's leading thinkers about how technology and data can improve quality of care for patients. Dr. Donald Rucker is currently the Chief Strategy Officer of One Up Health, and he previously served as the National Coordinator for Health Information Technology from 2017 until 2021. In this role, he led the development of the 21st Century Cures Act interoperability rule. And we'll hear today about how this regulation can enable data exchange and give patients access to their data. Welcome, Don.
We put excellent. Hi, everyone. Wow. Thanks, Craig. Thanks, Norm. Kenley set up what I'd like to talk about, really frankly, and have our discussion with Craig perfectly, which is the data that we're going to see in healthcare, I think is actually going to change quite a bit, because there's a conjunction of the technologies we know from just our daily lives, right? The whole cell phone mediated world, if you will, the web world, and then some new data standards, as well as some federal rulemaking, actually the Cures Act law, that will, I think, really the intent of Congress almost unanimously back in 2016, this all takes a while, stunningly, to really open up patients' EMR data to the ability for apps to process it. And I think that's going to have a lot of implications for this audience.
Great, thanks. So we thought it'd be worthwhile to start with some level setting, right? I think we could probably make a few people's heads spin, just by starting off with one sentence full of acronyms. I think we've all heard the terms FHIR APIs to achieve HL7 via REST. So let's parse this sentence. What do each of these terms mean, and why are they relevant to our health data organization members?
Yeah, so I think the key, there are a couple, concepts here, and this is really, I think, this technical thing is sort of at the heart of it. So let's parse that out a little bit. I think the first realization is skip healthcare. Just skip healthcare. Just think about the apps on your phone, right? we have all of these icons on our phone, and we can click on them and, get something. Every one of those things is basically talking through an API, an application programming interface, to some big iron server or cloud software base, right? There's almost no software actually running the things we want on the phone. So if it's airline, I'm in a hotel room, as you can probably parse out on a CME class today as it happens, right? The airline travel, the flight's on time, it's late, whatever, the seat, all of that is coming from a server, whether it's, your sports scores, your bank account, the weather. So all of those things are working real time through application programming interfaces, right? So then the next concept, so that gets to the API part of it. The next concept, which isn't in the acronym, but it's implicit in the acronym, is how does the little app on our phone talk with the back-end server? And that actually has had some amazing advances, and the advances have mostly been in simplifying it to make it really fast and really powerful. And there are really sort of two parts of that. With any API, you have the API protocol. How does the phone talk with the computer through a network over the internet? And then you have what data is being shared. And there have actually been advances in both of those. So let's start with the data being shared. To lay one more acronym on you that you've probably heard, it's called JSON, J-S-O-N, JavaScript Object Notation. Think of this as a really simple way of representing data. And unlike the data things the representations we had in the 90s for sure, and even frankly, some of the XML things that are sort of at the borderline, this is something you can just open up in a word processor and largely understand. There's no real computer science here. That's the brilliance of it. On the server, on the protocol side, there's something called RESTful. Like, you don't have to know what. So RESTful is, I don't know, there's probably some word for it, but RESTful is a combination of a 4-letter acronym with a modifier. So the REST part of it, which is capitalized, the FUL is lowercase, is representational state transfer. What the hell is representational state transfer? It's the simple gets and puts that say, go to this IP address, get this data, or put it there. It honestly is highly unlikely to be any simpler. This has powered the internet for the last 20-odd years. A guy named Craig Fielding at UC Irvine and his PhD thesis described this. This is what allows the internet to be alive and for these apps to actually do stuff. I may be the only one who's old enough, there might be one or two others, I'm sure, who remember the internet in the 90s. It was all page views. You couldn't really calculate, you could barely maybe pay with a credit card. It was all, basically just looking at a page. REST, that protocol, allowed us to look at individual data elements and increase the volume of data that NAHDO members now will increasingly have access to by many, many orders of magnitude. So we've talked about the API, we've talked about the data, we've talked about the protocol. How is that related to healthcare? So, right, everything on your phone uses JSON and RESTful APIs. Well, around 2000, people were trying to move away to go beyond lab tests and get more charts, the entire medical record in to HL7. And there was sort of a interesting aborted try of something where people decided, let's try to build this object-oriented world. That's a geeky computer term from the 90s that was very much in vogue then. It sort of passed out of fancy, that would still use in some ways. And the health IT industry tried it and it failed. It went nowhere. It just landed flat on its face. It was too complicated. Nobody could figure it out. So what was the retreat position? Well, the retreat position was, there's two parts. One is they just said, okay, well, let's just keep the XML version of the chart. So you've heard, CCDA, the clinical document architecture, and CCDs, the clinical document summary, basically. Those are typically XML documents. So that was left. But the real insight was from a gentleman named Graham Grieve from Australia, who said, hey, every other computer operation in the world is using JSON to do everything they need to do. Why don't we do that in healthcare? So FHIR, Fast Healthcare Interoperability Resources, again, you don't need to spell out any of these acronyms ever, as far as I can tell. They stand on their own, and nobody even probably typically knows what they stand for these days. It's just saying, we're going to put a healthcare layer of varnish on the JSON. So we're going to represent JSON objects, patient, insurance coverage, lab results, notes, visits in these, predefined resources. Those are called FHIR resources. There are roughly 150 of them. And all of a sudden, this makes what we've wanted to do in healthcare, which is really open up computing about the essence of clinical care, not just the lab results, not just the X12 claim, which this community has spent, I'm sure, lots of times analyzing and trying to infer clinical data from claims. Opening that up with, fully computable versions of the chart, typically the US core data for interoperability, so a subset of that. I know that's like more acronyms than anybody should be forced to even think about in one setting, let alone one day. But Craig, hopefully that gives a little bit of a level playing field to everybody and increases everybody's comfort on the what we're talking about here.
Well, I'll tell you, I've been to a lot of NAHDO and HIMSS conferences, and that's the best explanation of FHIR and its use that I've ever heard. So thanks very much. I'm sure that was really useful to our audience. So we've heard that—
Well, I've had some practice in explaining it.
I bet you have. So we've heard that the Office of the National Coordinator and the Centers for Medicare and Medicaid Services are working on a new regulation related to interoperability. So what might we expect from this regulation? And, building on FHIR, we've also heard this term bulk FHIR, and that it actually may be pretty applicable to health data organizations. So could you please speak to those two questions?
Yeah. So actually, there are a couple relevant rules for this audience that are in play here. Let me start with maybe the simpler, less transformative ones, which are in ONC, Office of the National Coordinator, which is a staff agency within Health and Human Services, as opposed to HHS, for example, or CDC or NIH, which are operating divisions. So ONC, in conjunction with HHS, just released this week the provisions for information blocking. Congress and the Cures Act said, hey, sharing data with patients and their entities is not optional anymore. If you don't share it, it's information blocking and there are penalties. And what the final rule here is that these penalties are going to be based on payment. So you're not going to get your MIPS bonus. You're not going to get your updates if you're in the hospital program. So these are some fairly real dollars if you're in an accountable care organization. And if you don't boot out the members who aren't interoperating, you would not be eligible for the ACO program. So some pretty real things. ONC is also working on a really sort of almost, frankly, I hate to say this, but a backwards step with something called TEFCA, which is really for the incumbent EHRs, one patient at a time. So probably not a big benefit to this organization using the 1990s protocol. We talked about all this stuff that's obsolete. TEFCA is all this obsolete stuff. They hope eventually to get to fire data, but they don't really understand the API part of it. So, we'll see how that all plays out. There are a lot of people involved, and hopefully some of the anti-competitive information hiding aspects of that will go away. Potentially the biggest proposed rule that should be coming out, let's say any week or any month now, is a rule that CMS has put out or proposed. There's a whole federal rulemaking process, and that rule doubles down on FHIR APIs. So in 2020, as part of the initial Cures Act rulemaking, CMS said that payers have to provide their claims data to patients and their apps via a FHIR API. CMS is now proposing to do this with for providers. So payers have to provide providers with this API, right? So these APIs are real time, right? So this really changes the nature and the volume of the game, as well as to other payers. Now, you might ask, why would a payer need to provide data to another payer? This is when insurance coverage switches. Switching between MA plans or between MA and fee-for-service. So all of that, CMS has vast computational needs, as everyone on this audience knows, and they're doubling down on using FHIR.
Great. And so what is this bulk FHIR? Actually heard you give a talk that featured this at a conference recently.
Yeah.
So it definitely piqued my interest, and it seemed applicable to our membership.
Yeah, bulk FHIR is really the thing for this audience that's really powerful. So once we had under the Cures Act APIs without special effort, which meant that the electronic health records that are certified had to convert the core data, med list, problem list, allergies, the notes as text, into FHIR. And working with Ken Mandel at Boston Children's and his team, we said, if payers and the people who want to hold providers accountable, which I think everybody in NAHDO basically is part of that community, they should be able to get this modern data. So every EHR, as of last year, is required to have a bulk FHIR API. Now, honestly, if I had to do it over again, I'd probably call it something besides bulk. I was sort of thinking Costco when I was talking with Ken back 5-6 years ago. I'd probably call it some like non-communicative thing like population health resource something. But bulk actually does communicate what it is, which is a batch mode. So it's not an API, but this could be everybody that you have a legal right to the data, in the first instance under the HIPAA treatment payment operations exemption. But obviously a lot of the APCDs and other folks have other legal claims to this data. So you can access from the EHR, from the providers, data on a population of patients. So for the first time ever, I would say, with clinical data, as opposed to maybe claims data or things that are harder to get, with normalized clinical data, you're going to be able to compare performance of providers on clinical care. So the old, every clinician has always said, my patients are sicker. Therefore, don't bother me, go away. I don't want this analytic stuff. Finally, for the first time, at least in my career of, whatever, I've been at this since working with John Eisenberg as a med student back in the 70s, we actually have a clean computable data stream. So bulk FHIR, it's an HL7 standards organization protocol. You can just Google HL7 bulk FHIR. You can see the protocol, but you should be able to ask for that with anybody with a certified EHR, which is basically everybody. It's still early, so I would certainly say there's lots of rough edges at this stage, but I think that will actually transform on the payment side our ability to look at what we're getting in American healthcare, and I think will be very complementary to the work that you're doing.
Great. And one other question that I think is worth thinking about is, what are some of the trends that are happening in interoperability beyond these impending regulations? And, why do you think that we should be optimistic or hopeful that interoperability will live up to the promise that some of us have been thinking about for a number of years?
Yeah. Well, I think the mega trend is it's going to be increasingly harder for healthcare not to be part of the modern digital economy, right? We have things like Portal. My mother, unfortunately, just got hospitalized yesterday. And so my brother in New Jersey is, cutting and pasting snippets of her Portal information and printouts from the nursing unit for the family to look at. While that's a far advance from what was before, which was nothing, it's not exactly the way we act with any app in the world. So I think it's going to be harder and harder for some of the incumbent providers and incumbent EHR to hide that information behind excuses like we're protecting patient privacy and stuff is not ready. I think it's just that delta is larger. Obviously, the federal government, which, because of the vagaries of our payment system, which actually incent non-interoperability, right? As everybody on this call knows, these big delivery systems hate sharing information because their business models are made on hiding the information, capturing all the referrals, making sure no high margin referral ever leaks out of their system, and then providing all or nothing contracts to payers. We all know that. This world may change, but certainly the federal government has to do regulation here. The Cures Act represents that, and you're already seeing the CMS. Even last week, 2 weeks ago, Michelle Schreiber, John Blum at the NCQA event talked about using FHIR API, switching the whole quality measurement process over to FHIR over time. Again, this is probably a 10-year process, to be realistic. NCQA is moving all of the work of HEDIS, which now is a fairly manual thing, is moving to FHIR in the cloud with the HEDIS measures running the containers. That's their plan. They have an early adopter program there, which we at OneUp are participating in, along with a couple other tech firms. So I think this is all coming.
Great. So do you have any final concluding thoughts for our membership as we go forward?
Yeah, well, first of all, you guys are doing a great job. I think you're one of the, you're really part of that transparency and being smart about healthcare collectively. So, congratulations to you. Hopefully this work will provide you with more tools, more insights, and things that are coming way closer to real time. So I think there's a shared optimism for all of us here.
Great. Well, thanks so much. Certainly best wishes to your mother. And we really appreciate your time. This was an outstanding start to our annual conference, and we're really grateful. Thanks so much.
Thanks, Craig.
Thank you, Craig and Don. We'll see everybody in just a few minutes at our next session. See you soon.
Thank you.